We're live.
Good afternoon, everyone. I'm Tony Freeman, president of the Charlotte chapter of the Links Incorporated, and I want to welcome you to our program, Matters of the Heart. First, I want to let you know what it means to be a link and why this important topic is so vital. There are 16,000 professional women of African descent and 292 chapters of the Links Incorporated. It's one of the nation's oldest and largest volunteer service organizations of extraordinary women who are committed to enriching, sustaining, and ensuring the cultural and economic survival of African Americans and other persons of African descent and ancestry. The Charlotte chapter is one of 292 chapters, and it was established in 1955. Today, there are 55 active members, and we're small by design. Each chapter is limited to the number of members, but we also have 40 members who have retired from active service. Health and Human Services Committee is the group that's responsible for organizing today's program. But why is this important to us? We've taken an aggressive stance against heart disease because it's the number one killer of African American women. It's chronic health disparities that persist in Black communities and the results of decreased life expectancies of African Americans that makes this topic so vitally important. We know that heart disease develops at a younger age in African Americans, and I didn't know until I read some research that nearly 48% of African American women and 44% of African American men have some form of heart disease. Excuse me. During this broadcast, you'll have the opportunity to make donations directly, to the American Heart Association. You can do it by going to Charlotte, North Carolina, goredluncheon.heart.org, or really, if you're technology savvy, you can just go ahead and text 41444 and make a donation to this very important topic. I now like to turn the program over to our member, Dr. Adele Anthony Williams, who will introduce the panel and also our special guests. Adele.
Thank you so much, President Freeman. Good afternoon, everyone. Thank you so much for joining us. We understand you can be anywhere today, and we really appreciate that you are choosing to spend your time with us. Again, my name is Adele Anthony Williams. I am a proud member of the Charlotte chapter of the Links Incorporated. I am also an anesthesiologist and pain management physician, a wife, a mother of two amazing sons, one in college and the other in graduate school. I've had the distinct pleasure of working with the American Heart Association closely this year as a member of the executive leadership team, and I'm so proud of what they've been doing to advance heart health and health access and to be a relentless force for longer and healthier lives in our community. As you know, February is American Heart Month, when we particularly acknowledge the Go Red for Women campaign. I personally love the color red, and I love that we have a great reason to wear it in support of education for women's heart health. It is in this spirit that the Charlotte chapter of the Links is so excited to present Matters of the Heart, a discussion about women and heart health with a focus on the African American community. We will also discuss the intersection of COVID-19 on cardiovascular health. We have an outstanding panel of guests to help us in this conversation today. This is going to be quite informative, inspiring, and transformational. It gives me great pleasure to introduce our panelists. We have Erin Link. She is the Executive Director of the Greater Charlotte American Heart Association. After serving as Nashville's Vice President of Development, Erin joined the Greater Charlotte region 2 years ago and is doing a yeoman's job broadening relationships. Dr. Jerome Williams Jr. is Senior Vice President of Consumer Engagement and Corporate Health at Novant Health. Dr. Williams is an interventional and nuclear cardiologist with over 20 years of clinical practice, having served as Division Chief and Chairman of Cardiology, as well as Medical Director of Research at Novant Health Heart and Vascular Institute. We also have Julia Allen, who is currently a Vice President and Employee Relations Manager at Bank of America here in Charlotte. She is a heart attack survivor and one of 9 women in the country selected to represent the National Go Red for Women 2015 Rail Women. Before we get started with our program, we have just a few housekeeping items. This webinar will be recorded and may be used on other social media platforms for educational or promotional purposes. We welcome and encourage questions from the audience. Please use the Q&A box to write your questions, and we will make every effort to get to all the queries. We have set aside dedicated time for Q&A at the end of the hour to allow input from you, our audience. So I would like to get started with you, Erin. Can you open the discussion today by helping us understand what some of the data is telling us about heart disease in women in this country?
Yes, thank you so much. And I'm so pleased to be with you all today. Go Red for Women has been committed to the health and well-being of women and their heart health for over 17 years. And really, the American Heart Association stepped into that space because we saw that the alarming numbers of women losing their life to heart disease. And the reality is that more women lose their life to cardiovascular disease than all forms of cancer combined. After being with the organization 14 years, it continues to be shocking to say that out loud. And really, one is too many. One life is too many, which is why we still stand together and shout this message so more people can know and understand. Next slide, please. I want to specifically point out some of the disparities we see. Nearly 45% of women age 20 and older are living with some form of heart disease, and that's all across ethnicities, that data. If you look specifically at Black women in our country, 1 in every 2. So most of the time you hear the statistic 1 in 3 women will lose their life, but if you hone in specifically on the Black population, it's 1 in every 2. And 56% of Black women age 20 and older have hypertension, and only 26.5 have it under control. We know that hypertension is one of the biggest risk factors for experiencing a heart attack or a stroke. Next slide, please. I want to point specifically to, we'll move past the data in a minute, but I want to specifically point to the great progress that's been made, which we're really proud of, but then also look at what continues to be an issue. So Black adults are 32% more likely to die from cardiovascular disease than their non-Hispanic white counterparts. And that's not okay, which is really why the Heart Association has stepped into a even more aggressive approach to how we're going to meet the need of everyone in our community. Next slide, please. One more slide for me, please. So for the American Heart Association, our mission is to be a relentless force for a world of longer, healthier lives. And I think something really poignant about that is that it's for longer and healthier lives. And we know that it doesn't specifically say anything about heart disease and stroke, because we know if we're addressing the core issues to health, we're going to improve our cardiac and stroke numbers as well. As an organization, you see on the screen our guiding values to improving and extending people's lives, speaking with a trustworthy voice, inspiring passion, and ensuring equitable health for all. And so really our strategic value proposition is that AHA is a catalyst to achieving maximum impact in equitable health and well-being. And I emphasize the equitable part. Next slide, please. Most recently, we came out with a presidential advisory actually speaking into the evolution of our work. And so as a 100-year organization, back in 1924, we really started as a public and provider education organization. And over time, what we've realized and what science has told us is we need to do more. And our mission has expanded to make sure that we are driving change in communities. And so most recently, you'll see that endpoint that's noted as 2020, structural racism is now a cornerstone and commitment for our organization to address the challenges that our communities face. Next slide, please. And I want to put that in context. I recognize that this is not a unique story that I'm going to share, and that there are so many who have experienced this personally, but it's often helpful to put a face and a name with what it is we're actually talking about. For our organization, we recognize that Michelle, a 53-year-old Black female who's an hourly worker, is living a very fulfilling, great life. And unfortunately, she experienced a mini stroke, and she's diagnosed with hypertension. And the doctor makes some recommendations on how she can improve her life and make sure that she doesn't have future health complications. Unfortunately, because she's an hourly worker, there's no insurance, and there's a barrier for her to follow those discharge instructions. And then there's no primary care provider, and she can't afford her blood pressure medications. She moves on, and there's limited food options, and that really equates to her eating primarily fast food because that's the only option for her, which really just exacerbates her blood pressure. And there isn't anywhere where she can safely walk. So therefore she can't get the physical activity she needs as well. And the list kind of goes on and on as you work your way around this visual. But what we recognize is it's more, our work is more than just making sure she gets the great care she needs within a hospital setting. It's make sure she has the environment around her where the healthy choice can be the easy choice, and that she can have the healthcare provided to her that she needs. Next slide. So for these reasons and more, we established our 2024 impact goal. And that is stated as every person deserves the opportunity for a full, healthy life. As champions for health equity, by 2024, the American Heart Association will advance cardiovascular health for all, including identifying and removing barriers to health care access and quality. And again, pointing to that, addressing health disparities and making sure there is equity in all that we've done. And you know, it's great that we make a statement like this, but what does that mean, and how are we going to implement this promise to our community? And so if you'll move to the next slide, you'll see, you may have to click a couple of times, there are a few boxes there, but we as an organization have made 10 commitments. 10 commitments to path us towards our 2024 goal. And this slide has 4 of those. It's really focusing on research, so committing more dollars to address health inequities and structural racism as it pertains to research. So what is the science telling us? Making sure that communities have the resources they need to address those health inequities as well. Ensuring access to care. Medicaid expansion is incredibly important to our organization, and so we continue to advocate aggressively. And then targeting industry. We know there are so many for-profit organizations who target unhealthy products such as sugary beverages and tobacco and e-cigarettes to our under-resourced communities. And if you'll move to the next slide, please, you'll see 3 more. Addressing hypertension, as we know, as I shared before, the statistics are staggering, and we know we have to do more in our communities of color to address hypertension. We know that we need to make sure with our quality initiatives that the data we're collecting in partnership with our hospital systems is collecting the right data to tell us how to address the issues and the disparities that we're seeing. And then we're going to be working to make sure that with our CEO roundtable that we're doing our part to dismantle inequitable workplace practices and policies. If you'll move to the next slide, there are the 3 final promises from our organization. We are going to be crafting a platform for digital learning that is focused on clinicians and health professionals and scientists that really speaks into structural racism and health equity and how that relates to the care they're providing to their patients. We're also going to make sure that we're prioritizing scientific journals on disparities. We have amazing journals, but are we making sure the storytelling is the same in those journals as it is in all other? And then we, as an organization, are going to continue to commit to workforce diversity as well. One of the things that we continue to see inequities in as well is CPR. So if you'll move to the next slide, I want to specifically pause for a moment because CPR is one of the most powerful things that we as individuals can take and own and do as an action and a point of education. So women need CPR too. That's no surprise probably to you, but the numbers really do tell a story. So only 39% of women receive CPR from bystanders in public compared to 45% of men. That's shocking and really unfortunate. Men's odds of surviving a cardiac event are 23% higher than women's. And there are many reasons for that, whether that be the fears and the concerns, but and the myths as well. But the reality is that women need CPR, and we as women need to know and understand how to perform CPR. So if you'll move to the next slide, I want to show you the 2 easy steps. And so I'm gonna walk you through this now, and then I'm gonna tee up a video that really does a great job. So 1, learn the 2 simple steps. Bystander CPR is so easy, and we know that the science tells us that if you don't know someone and you have never had CPR full training before, it's great for you to do the 2 easy steps. 1, if someone collapses and is not breathing, call 911. And 2, push hard and fast in the center of the chest. It's that easy. So with that, I know we're going to transition to a great video. I look forward to answering your questions later in the program. And thank you so much for allowing me to share a little bit about our work and passion.
If you see a teen or adult suddenly collapse, it's important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to send someone to call 911 or call 911 yourself.
I will stay on the phone with you until help arrives.
Then get directly over the victim. Put the heel of one hand in the center of the chest. Then put your other hand on top of the first.
I need you to do it this fast. 1, 2, 3.
Then push hard and fast in the center of the chest until help arrives.
11, 12, 13, 14, 15.
It's important to push at a rate of at least 100 beats per minute.
20, 21.
Let's hope you never have to use hands-only CPR. But if you see a teen or adult suddenly collapse, don't be afraid to try it. Remember, call 911, then push hard and fast in the center of the chest until help arrives. Your actions can help save a life.
Wow, thank you so much for that, Erin. The statistics speak for themselves, that almost half of African-American women over the age of 20 have high blood pressure. I am one of those people. I think all the women in my family as well have high blood pressure. 1 in every 2 African-American women have cardiovascular disease compared to 1 in 3 white women. African-American adults are 32% more likely to die of cardiovascular disease, and men's odds of surviving a cardiac event are 23% higher than women's. These are just remarkable statistics, as well as knowing that any of us can help save a life by just calling 911 and pressing fast on a chest by doing CPR. This issue is so important, and there's a lot to unpack. We thought it was really necessary to put a tangible face to this issue, and we are so fortunate to have with us Julia Allen this morning. Julia, you have such a remarkable story that's sure to surprise and inspire. You have an amazing career, you're a wife and a mother of 3 sons, but you're also a survivor and equally a motivator. Can you please share with us what happened to you in 2013?
Thanks so much, Adele. Thanks to the Links group for having me here today. It's really a pleasure. I've told this story, I know I've done well over 50 interviews, and I believe I've told this story probably 100 times since my heart attack. You know, being a 7-year survivor, it gives you hindsight. And with that, what's important to me is to share what happened to me, how I got there, and it's important to save lives. And that's why I do this. That's why I'm so passionate about it. And it's such a privilege for me to be a partner with the American Heart Association and the Go Red for Women campaign. Normally what I do when I tell this story, people want to hear about what happened that day. What did you feel? What were the symptoms? Today, I'd like to share my story a little differently. I kind of like to maybe start at the end, jump to the beginning, and go back in a slightly different order. And the reason I like to do that is I like to share what I missed, family history, signs, and share that portion of my story so that if it sounds familiar to anyone that's listening today, it may prompt you to go to the doctor and talk to someone and to get some help. I'd like to start by sharing that both my mother and myself are heart attack survivors. My mother had her heart attack in 2006 at the age of 63. I had my heart attack in 2013 at the age of 44. So just about almost 20 years younger than her. I'm 52 now, she's 76. We're both in good health and both doing well. In my case, lots of family history. As I said, my mother is a heart attack survivor. My father had heart disease. 3 out of 4 of my grandparents had heart disease. My brother and my father were both diabetic. I had gestational diabetes during my first pregnancy, which could lead to diabetes later in life. Thank God that hasn't happened. My father was a smoker and he also had a stroke. So as you can see, just in my immediate family, there is a lot of history there. Adele, you mentioned that I'm the mom of 3 awesome sons, if I may say so myself. They are now 21, 17, and 13. When I had my heart attack, they were 14, 10, and 6. So definitely I had a reason to live. One other piece of information that's important to keep in mind is that after I had my heart attack, because of some of the symptoms that I had been diagnosed with, my children's pediatrician did a cholesterol test, and we found that at that time, my 14-year-old, who was a football player, a national and state champion in the middle distance running, had high cholesterol, a 14-year-old. So I'm painting a picture here for you guys in thinking about family history and how if you don't work with your doctor, these things can continue. I'd like to begin, now that I've shared some of that history with you, by if you don't remember anything that I said today, I'd like you to take away and remember your body talks to you. Listen to it. Your body talks to you. Listen to it and don't ignore it. Years before my heart attack, probably 5 or 6 years before and leading up to it, when I would go to my dentist and to my eye doctor, to their credit, they would take your blood pressure. And they would always say to me, your blood pressure is a little high today. And I never paid attention to them. I always discounted. I said, oh, this is because I was rushing to get here from work. Let me just calm down. It's good. And I never paid attention. And they said, Julie, your blood pressure is high. You should get it checked. And I didn't pay attention. Sign number 1. I tried to donate blood. And I remember they said, yeah, Miss Allen, we can't take your blood. Your cholesterol is high. Sign number 2. Now, this is years before, right? 5 or 6 years before. When I had my first child, I had to have an emergency C-section because my blood pressure was so high. What started out as a normal delivery quickly went wrong because my blood pressure was so high. We immediately had to get him out to save both him and myself. Fast forward now to my 40s. I start to have these very awful, very long menstrual cycles that were lasting 3 weeks, right? That's not normal. I continued to tell myself that it was normal because I was 40. Hey, maybe I was premenopausal, right? My body was changing and this was temporary. It's going to go away. That's not going to keep happening. Well, it did not stop and it lasted for well into 2 years. Then it started to become accompanied with very painful cycles, extreme fatigue, and very, very indescribable heavy blood loss. Now let's fast forward. Now I have a heart attack. 6 months after my heart attack, now the picture's starting to come together. 6 months after my heart attack, while being prepped for a partial hysterectomy, yes, heart attack, 6 months later, partial hysterectomy, while being prepped for surgery, talking to the surgeon, and he said, made me aware that I was extremely anemic. I did not know that I was anemic. No one had ever told me that I was anemic. And when I say anemic, I believe like a normal hemoglobin, I'm not a doctor, the doctors can correct me when I'm done here, is like around 15 or so. I was at like 6.5, 6.7. So I was extremely anemic. And remember, I was telling you before when I was having the heavy cycles, I talked about the extreme fatigue, right? So now let's start putting the picture together. Extremely anemic. And anemia is when, you know, the red blood cells, they supply oxygen to your body. And so when that oxygen gets low, now your heart has to start working much harder to supply your body with oxygen. So I'm hoping that the picture is coming together now, right? So I'm anemic, my heart's working really hard. I've got all this stuff going on. My doctor asked me how I was feeling, and I never told them how tired I was. I thought, again, that was normal, ignoring the symptoms and not listening to my body. And I think had I told them how I was feeling, it would have led to more questions, right? So not blaming myself, not blaming the doctor. I'm just making a point to tell your doctor everything. So after, right before the surgery, and I found out I was anemic, that surgeon said to me, you know, it's a possibility that the anemia may have not necessarily caused the heart attack, but definitely it didn't help it. And it could have pushed it to happen a little faster because my body was working so hard, right? The day of my heart attack, April 15th, 2013, is a day that I'll never forget. It began with me telling my kids and my family, hey, I love you, and I'll see you later tonight. It began with symptoms around 8 a.m. and I ignored those symptoms. I felt like I had the flu. I felt like I needed to throw up. I felt like I had the worst case of heartburn that you could ever describe, or you could ever imagine. And so I ignored the symptoms, right? You guys seeing the pattern, ignore. I ignored the symptoms, and I sent one of my teammates to Harris Teeter to get me some chicken soup, right? Because chicken soup fixes everything. The symptoms went away, and then they came back later in the day, maybe around 11:30 or 12-ish. I continued to work because I felt like, I couldn't leave work. I couldn't leave my team. I was the assistant manager at the time and at a small community bank. And I felt like, if I leave, this bank isn't going to run, right? How many of us do that? I continued to work. I called my husband and shared my symptoms. I can't repeat on this call what he said. And then I called my doctor thinking, she'll just get me in. She'll see me. I didn't want to go to the hospital. I didn't want to pay the bill, the copay for the ambulance. And yes, I had insurance, right? But I didn't want to pay the copay. I didn't want to, what I assume, have them tell me in the hospital that I just had the flu and send me home. I didn't want to waste the doctor's time. I thought nothing was wrong with me. I just thought I had the flu and I needed to go home and go to sleep. I was a mom, I had my career, I was a wife, I was trying to be everything to everyone. And I I was hesitant to leave work because I had been a stay-at-home mom for 7 years. I had just gotten back to working. I literally had to start my career all over at the bottom. I was working my way up. I was worried about what people would think if I called off work. So all these things going on in my head. So I called my doctor. The doctor said, nope, go to the hospital. So, with the back and forth, I agreed. Made another mistake. I drove myself to the hospital. Now, understand, guys, I had already had a heart attack at work. I'd already had heart attack number 1, unbeknownst to me. I just thought I had the flu. I decided to get in my car and drive myself to the hospital. On my way to the hospital, it dawned on me that my children would be getting off the school bus and letting themselves in the house, and no one would be home. So I stopped at home first and I wrote a note, hey kids, mom will be a little late. And I made them a snack so that they wouldn't be hungry, waiting for me to come home. And then I drove myself to the hospital. Once I arrived at the hospital, I made it to the desk. And I think there were 2 angels, one on this arm and one on that arm, that carried me in the building. Because once I made it to that desk and I gave them my name, that was it. I collapsed. And I had my second heart attack in the hospital that night. So there are lots of things that I missed. There are lots of lessons that I've learned. And I just hope that by sharing my story today, Adele, that it resonates with someone and it helps save some lives.
Wow. Thank you so much, Julia. That was incredible. As a physician, I can absolutely relate to the clinical components of what you described. As a working mother, as someone with high blood pressure who's had it for 15 or so years, so much of what you said is so relatable. I thank you so much for your candor in describing the simple things that in retrospect, you realized that you ignored. Some might want to be honest about the fact that they were signs that were just brushed aside. And I thank you for sharing that. Dr. Williams, Ms. Allen's testimony, I suspect, is probably not an unusual story for you as a cardiologist. Can you fill in for the audience in your medical perspective the nuances of her story, as well as what you see in terms of disparities in the African-American community? Can you paint a picture for everyone?
Yes, thank you. And thank you, Links Chapter. Thank you, American Heart Association. And most importantly, thank you to my wife, Adele Anthony Williams, for partnering and having me collaborate with her on this important topic. Julia and Erin, they really shared all of the medical aspects of women and heart disease. And I'm going to touch on that as well, but I'm going to also broaden the scope a bit. As you mentioned earlier, I am a cardiologist. I've been practicing for about 30 years and taking care of patients, excuse me, with the similar signs and symptoms that Julia described. However, in my role as Senior Vice President for Consumer Engagement for Novant Health, I am responsible for our strategic design, implementation, and direction of our community wellness, community benefit, corporate social responsibility, and community engagement programs. At Novant Health, the mission at Novant is to improve the health of communities one person at a time. That's not insured communities, that's not rich communities, that's all communities. And so therefore, we have to have an intentional strategy to improve the health of communities. Next slide, please. I think it's important to understand that when we talk about improving the health of communities, our vision in community engagement is to achieve health equity. Now, when we talk about achieving health equity, really what we're talking about is change, right? And when you talk about change, when you look at all the business literature, a theory of change usually is a linear type of activity. You have some inputs, you have some activities, you have some outputs, and then subsequently some outcomes. However, when you talk about achieving health equity, it really is not linear. You have to look at many different factors simultaneously. Sometimes those factors are a little bit more intense than other factors, but you really have to delve into all the factors simultaneously. And when you look at this strategic framework that we have at Novant Health and Community Engagement, the outermost circle, structural inequities and biases, we can't ignore racism. We can't ignore sexism. We can't ignore xenophobia. We can't ignore ableism. We have to confront those structural inequities and biases because it lays the foundation for inequities and therefore disparate health outcomes. We also have to understand within the communities that we're focusing on, and we're focusing on African American women as a community. Tony mentioned there's 16,000 strong links leaders across this country. We have to listen to those individuals and understand what are some of the solutions that they bring to the table and implement those solutions. Now, the big part here, social determinants of health. Social determinants of health. We understand that only 20% of chronic medical conditions have to do with biology and have to do with genetics. Therefore, 80% have to do with what we call social determinants of health, or behaviors or the environment that we live in or the environment we don't live in that have direct impact on our health. So what are some of those social determinants of health? Food insecurities. Erin mentioned that earlier. Lack of access to healthcare, housing insecurities, transportation insecurities, lack of upward mobility. All of those have much more profound impact on one's health than just biology and genetics. When we talk about our strategic priorities on how we plan to create change in communities and those 16,000 African American women that are in the links, we have to start with access, not just access to healthcare. Yes, we must build more clinics and have virtual health offerings and hospitals in many neighborhoods that lack healthcare, but we also need access to capital, access to social capital, access to upward mobility. Once again, we have to listen to the communities that we serve. We have to hear the story that Julia shared. We have to understand that physicians, providers, healthcare institutions must understand cultural competency. So we have to understand the voice of the communities that we serve. Those voices are different by each zip code. And it's a never-ending process of learning and understanding cultural competency across our communities. We have to leverage partnerships. Okay, Novant Health, we're subject matter experts in healthcare, the delivery of healthcare. However, partnerships with the links, partnerships with the American Heart Association, they're vitally important to drive information, to drive knowledge. As a healthcare system, we are an anchor institution in our communities. Therefore, we have to create a platform from bringing subject matter experts such as the American Heart Association, such as other institutions to the table, so that we can leverage that knowledge and create a greater impact. When we talk about impact, we have to have measurements. There are many states out there that don't measure data by race, okay? If you can't measure something, you can't manage it. If you can't measure the disparate outcomes that African American women are experiencing, then we can't really address the issue. So we have to understand that we have to have data and measurements in order to create impact. And then lastly, capacity building. Not just capacity building within our institutions to advocate for change, but capacity building in our neighborhoods and our communities so that we create agency, so they can create agency for themselves to advocate for themselves, to create the advocacy needed to change that outer circle structural inequities and biases. Next slide, please. So we've already heard a lot about the disease of heart disease and stroke in women. We clearly understand it's the #1 cause of death in women in the United States, period. It kills more Americans than all forms of cancer combined. So it's a big deal. It's a big a point that we have to address. We already heard that 1 out of every 3 people will die from heart disease or stroke. And we also know that stroke is the leading cause of serious long-term disability. Once again, this is information that we've shared in the past. Next slide, please. So 80% of cardiovascular disease is preventable. I just want to say that again. 80% of cardiovascular disease is preventable. So all of those deaths, all those disabilities, all the morbidity and mortality, we can alter by controlling risk factors, by controlling blood pressure, by getting our blood sugar under control, our cholesterol, losing weight. Now, once again, while those are very individual behaviors, we also have to look at the societal and systemic institutions that we have to address in order to have adequate nutrition. So it's very difficult to control your blood sugar and blood cholesterol if you live in an area that doesn't have a grocery store with fresh foods and fresh vegetables, right? So you see the tie-in between individual behavior and in society inequities. Exercise. Exercise is vitally important. But once again, if you look at the social determinants of health, if you live in neighborhoods where there are dogs or animals that are roaming along the streets and are threatening to individuals, if you live in neighborhoods that may not be as safe or poor lighting, there's very little chance of one exercising. Personal behavior of avoiding smoking and excessive alcohol. Many folks will engage in those types of behaviors as coping mechanisms to, once again, systemic and institutional challenges, such as racism, sexism, homophobia. And then last but not least, we have to really address our behavioral health. It's very important in all aspects of not just heart disease, but health. Next slide, please. Now, with a specific focus on COVID-19 and heart disease, once again, we recognize that there is a disproportionate number of people of color that are succumbing to COVID-19. Why is that? Well, we also understand that those with significant comorbidities, what are those comorbidities? Hypertension, diabetes, lung disease. Once again, all of the risk factors for heart disease increases the chance of you having significantly serious outcomes or negative outcomes from COVID-19 exposure. But specifically, there is a particular pathology called myocarditis, which is inflammation of the heart muscle from the COVID-19 virus. Now, individuals who are exposed to COVID-19 often will have what's called a hyperimmune response, where the immune system is really revved up. And when the immune response is really revved up, you can have damage to many different organs, the kidneys, the lungs, and as well as the heart. How is that diagnosed? Often people will come in with chest pains, shortness of breath. Sometimes folks will come in and it feels like they're having a heart attack, but in fact, what's going on is they have inflammation of the heart. Often folks will present with what we call sudden death or an abnormal heart rhythm. What's the treatment? Unfortunately, there's no definitive direct treatment for myocarditis. What we typically do is rest the heart, okay? What do we mean by rest the heart? There are often medications that we use that would reduce the load or the work of the heart. There's often mechanical devices that we can implant in a temporary fashion in patients to rest the heart. And more often than not, the heart will heal over time on its own and restore normal function. To date, we are not aware of the long-term effects of COVID-19 on the heart as it relates to myocarditis and inflammation, but studies will continue to bring us information on how best to treat this abnormal and very deadly illness. Next slide. I believe that is it. Now, This slide I just show you because I want to encourage all of our listeners, when it's their turn, please get the shot. What you see here are pictures of many providers at Novant Health of many different hues, races, and people of color. We want to educate the community that the vaccine is safe. We want to educate the community on the availability of the vaccine. And when it's your turn, please get your shot. Before this webinar this morning, I was down at the Spectrum Center where Novant has partnered with the Hornets and the Spectrum Center for a mass vaccination event. We were trying to vaccinate our communities. And I encourage all of you to use your distribution channels, especially to those communities of color, to share with them that the vaccine is safe, it's effective, and it could heal not just individuals and stop the transmission of spread, but also heal our communities. Thank you so much, and I look forward to your questions and answers.
Wow, thank you, Dr. Williams. That was so informative and detailed. We heard a lot about the social determinants of health, things like food deserts and access to care. And we heard from Julia Allen that sometimes the superwoman mindset that makes you successful in a career as a woman can sometimes work against you, as she was denying the fact that she had chest pain or symptoms and felt that she needed to get to work and make sure her children had a snack before she took care of herself. There were just so many pearls that were shared. I do want to backtrack one and ask the question to Dr. Williams. Do women present with heart attack symptoms any differently than men? Was there something that Julia Allen shared about her presenting symptoms that sounded familiar to you?
Absolutely. So the typical description of a heart attack is pressure, squeezing, tightness on the left side of the chest. However, women at times will have a different presentation. I don't want to use the word atypical presentation because once again, that throws off the topic and throws off individuals because it's not an atypical presentation. For women, usually you'll have neck pain, jaw pain, shoulder pain, upper back pain, abdominal discomfort. You can have shortness of breath. Pain in both arms, doesn't have to be pressure, but pain in both arms at the same time, nausea, vomiting, sometimes just sweating. Sometimes I just feel fatigued. I just don't have any energy. Sometimes indigestion. So there are a wide variety of symptoms that we as clinicians and healthcare providers must be aware of when treating all individuals. Once again, it goes back to not just understanding the medical pathology, but also having cultural competency and understanding how to interact with individuals of various cultures, races, and ethnicities.
Julia, I have a question for you. Have you made some changes in your lifestyle since you've had your cardiac event?
Yes, and I would like to say I'm perfect at it, but yeah, no. So one of the first things that they have you do after you have a heart attack is they send you to rehab. And it's so important to fully participate in that rehab all the way until the end, until you're discharged. Shortly after completing my rehab, I probably lost about a good 30 pounds. And so my household, my kids, my husband, we're all very much more aware of what we put in our mouths, trying to be more physically active. But I would be honest with you, Adele, it is exercise is the bane of my existence. I find myself more often than not making an excuse not to do it. And I know that I should. Amongst, I'm sure some of the folks listening here, I've gained a few COVID pounds. But here's the good thing is that my husband is totally my partner in this. And together, we try to cook together, do healthy things, healthy menu planning as much as we can. get out and walk together. My kids are always like, Mom, you shouldn't be eating that, right? So as a family, we have definitely improved, done the best that we can to make changes. Do I have some room for growth and to get better? Absolutely. But the difference now is that I am much more aware and definitely have strong partnerships with my doctors, both my primary care physician and my cardiologist. So some really good partnerships there, and really being aware and making those efforts.
Thank you so much. We're going to move now to our Q&A with our panelists, and I'm going to give the floor to Dr. Shawanda Spencer, who will continue this conversation with Erin, Julia, and Dr. Williams. Dr. Spencer?
Hello, everyone. Thank you so much, Adele. I appreciate that introduction. And I'll just take this time to just say thank you for all of the panelists, even as a provider myself and seeing some patients. And again, Dr. Shawanda Spencer, but I am a certified family nurse practitioner. And I actually just wanted to take a couple seconds just to give kudos to Dr. Jerome Williams as well. My husband had a health scare before, and we got the pleasure of seeing you. And he actually talks about you often when friends and things come up of talking about heart issues. So thank you for having that impact on him. We greatly appreciate that. And you talked about racism and things and sexism and things a lot in the community with healthcare and dealing with heart conditions, and it's prevalent. So again, I just thank you for sharing and making that a part of your practice as well with your patients. So we have gotten some great questions in the Q&A, and I'm going to address these appropriately to one of the panelists that I think would be better to answer them. However, you all are able to chime in. There was one question that Erin had actually addressed in the Q&A first, so I'm gonna leave this one, I'm gonna start this one with you. And we had a guest ask, was hypertension considered heart disease? So Erin, if you can elaborate on that and just talk about the detailed answer that you gave in the Q&A for everybody else, that would be great.
Sure. And I want to be the first to say I do not have a clinical background. I know enough to be dangerous. So I certainly don't want to overspeak. However, what I will say is we really look at hypertension as one of the major risk factors for heart disease. So it is not actually heart disease itself, but it is a risk factor, which is creating damage within your cardiovascular system. So there are certainly a lot of things, there is that genetic factor, but then there are also things that you can do that will increase your blood pressure. And so it's just keeping an eye on it. And I think Julia's point that she made earlier is just so important. Knowing what your regular blood pressure is, whether you're monitoring it yourself at home or going to your local Harris Teeter or Walgreens or whatever your place to get your blood pressure taken regularly is really important.
Thank you so much for that answer. Dr. Jerome Williams, can you elaborate on that just a little bit? And again, the question was, is hypertension considered heart disease? And along with that, can you just talk about the stages of hypertension?
So to piggyback on what Erin said, it is a risk factor, right? And so when we talk about hypertension, we're really talking about the pressure inside the blood vessels, okay? The pressure inside the blood vessels, the pressure that is exerted into the walls of the blood vessels. And when you talk about the stages, what I usually like to do is keep it real simple, okay? Don't make it complicated, keep it real simple. A normal blood pressure, 120/80 or less, okay? Anything above that is hypertension. Now, we do have stages of pre-hypertension, 130/90 hypertension, 140/90, but I like to keep it real, just straightforward and simple. If your blood pressure on a number of determinations or a number of measurements over a period of time is persistently above 120/80, then there needs to be some steps taken to address those blood pressure issues. Because as Erin said, in the long run, that pressure inside those arteries will cause changes to those arteries, damage to those arteries that can lead to further problems such as heart attacks and strokes. Now, not all individuals with high blood pressure, especially if it's just above 120/80, require medications, dietary changes, specifically dietary changes, low sodium diet, and exercise are quite effective. Now, That said, there are a number of individuals that exercise regularly, that eat properly, that still have high blood pressure that may require medications to control blood pressure in the long term.
Thank you for that answer. So just to kind of elaborate, or not elaborate, just to combine some questions that have come in that you kind of just touched on, but just to get a couple questions answered off of that. There was a question from one of our guests that read, in addition to diet and exercise, do you recommend preventatives, including aspirin and beet juice? And I thought that was a great question because aspirin has kind of gone both ways at some point with ages and research. And then now research has kind of gone the other way on, if over 40, you should take an 81 or not. So I thought that that was a very good question. So again, in addition to diet and exercise, do you recommend those preventatives that include aspirin and or beet juice?
So I'll just the aspirin first. Unless you have vascular disease, diagnosed vascular disease, there's no need to take an aspirin in this particular day and age. So what do I mean by diagnosed vascular disease? Yes, there was a time when we said if you have a number of risk factors, you should take aspirin. However, further research has shown us that individuals, aspirin is not innocuous, right? It's a great medicine, but it also has its side effects. It's a blood thinner. And so for some people, they have some minor and sometimes major bleeding effects. So you have to look at the risk benefit. And it's shown that unless you have major or any vascular disease, just to take aspirin in and of itself is not really recommended. Now, that said, I always say it's important to consult with your primary care physician first, because your primary care physician, I love what Julia said, is my partner, right? Is my partner. I think she used the word partner and on this journey that she's on, and she's on a journey. And the primary care physician will have very intimate knowledge of an individual's risk factors, family history, and other contributing factors to one's health. As it relates to beet juice, I can't really speak to beet juice. What I can say is there are a number of healthy food options that have medicinal type of effects, meaning they work like medicines. I can't really speak to beet juice as to being one of those medicines. I'm not saying it isn't, I just can't speak to beet juice specifically.
Awesome. So we're going to take two more questions. I think with all of the information that Aaron, Dr. Jerome Williams, and Julia Allen have given, between the conversations and their slides, I think a lot of questions and a lot of information has been addressed. So great job to all of you. But we got a question from Facebook and then two other quick questions from guests that we have. So we're going to address those and then we are going to wrap up. So the one from Facebook, it's a good question, but it's very detailed. And I'll start with Dr. Jerome Williams again, just the fact that you just spoke on how your primary care physician is your partner. But then Aaron, too, you can kind of speak on this if you feel you've seen this enough with people that have actually come into the American Heart Association and you've kind of dealt with this as well. So healthcare services are very hyper-specialized now. Do you think that has negatively affected the quality of primary care provider care, where we see so many symptoms not being diagnosed before catastrophic events happen?
So that's a question of either or, and it's
Right.
never either or, right? It's and. So what I do know and do believe is that there needs to be an increased number of primary care provider access points throughout our communities. We don't have enough primary care providers. Now, the lack of primary care providers, if I heard the question correct, doesn't negate the advantages of subspecialty care. There is a tremendous benefit from subspecialization, especially as it relates to surgical procedures, certain surgical procedures, right? So if you're talking about a bypass surgery, if you're talking about implanting of stents or defibrillators or implantable valves, those are highly specialized procedures that require the technical expertise of individuals in order to be safe and enduring and long lasting. But that said, we clearly need many more primary care providers. And when I say primary care providers, they don't necessarily have to be physicians either. Okay, primary care providers and access points could be physician's assistants, nurse practitioners, And so, yes, we need many, many more primary care access points throughout our communities.
Shawanda,
Yes.
can I speak to that question very quickly from the perspective of a patient?
Yep.
I hope it's okay for me to say, but both my primary care physician and my cardiologist are Novant doctors. And so within that system, they talk to each other. They can see everything. So when I go to my primary care physician, she says, well, I can see when you were at your cardiologist, I can see they did this, they did that. You talked about this, you talked about that. And vice versa. When I go to my cardiologist, she says, did you tell your primary care physician this? So it's almost like, because the system, they can see what happened in each appointment, right? They talk to each other, they communicate. One doesn't do anything without the other. And then I'm in the middle. And if something's missed, now I've learned to make sure that they both know, right? So that's why I use that word partnership, because it's my responsibility to talk to both of them, but then I also see that they work together and they communicate with each other. So it's truly a partnership with the three of us. And so I really just think that was really important to share that experience that I have personally.
Exactly. What you're speaking of is another term that we use is collaborative care. And it's very important for your providers to know each other, especially in your case when a catastrophic event has happened, for your primary care provider to know who's treating that particular part in detail of your body, and they should be able to talk. So a lot of that can kind of get missing when you have one provider at Atrium, so to speak, and then another provider at Novant. The computer systems are completely different. And now you're dealing with a lot of emails and faxes of information instead of being able to go into the same computer system to just look up information. So I think it's important when people have more than one provider to try and stay within the same system. Again, who you choose is preferential, and sometimes insurance has more input than what one would like about who they can see, when, how long, and how many times and such. But being in the same system, I think when you have a lot going on and a lot of comorbidities, is extremely important. And a lot of factors can be life-saving. One thing can get missed from one provider to the next, your meds can get changed and things can go awry very quickly. So a couple quick questions, and then we're going to wrap up and start to answer a lot of these other questions directly in the Q&A. But how many minutes of exercise would you recommend daily, or how many times a week, to actually strengthen the heart or to keep the heart healthy? If you are already a healthy person, or if you're a couch sitter, what's a good start, and how many minutes or activity a week should one strive for to keep and maintain a healthy heart? And Dr. Williams,
Erin, do you want to start? You want me to start, Erin?
Williams,
you can jump in, Dr. Williams. Go ahead.
So first and foremost, once again, I like to keep things very simple. Just walking, plain old walking, okay? And I would say start with 30 minutes a day, okay? And if your pace is, I walk a half a block in 30 minutes, or I walk 30 miles in 30 minutes, that's your pace. But just start with walking, and at the very least 3 times a week. But I like to say, get in some type of exercise every day, every single day.
And lastly, and this is the last one, but it's such a good question, and I think that this will affect in our community as well. I think a lot of people kind of steer towards this. And can being on blood pressure medication for an extended period of time, and this person particularly asked 20 years plus, have a negative impact on your health?
So I know that one's definitely for me.
Yeah.
So once again, it's not either or, it's really risk benefit, right? And so if one has a blood pressure without medications that's persistently 160 over 100, 150 over 90, then their risk, and especially if they have other risk factors such as diabetes, they're overweight, etc., their risk of stroke and heart attack is astronomical, okay? Now, by definition, if you are on any medication, even a Tylenol, by definition, you will have side effects. That's really a definition of a medicine. A medicine has to create some type of side effect in order to do what it does. So it's not, no, you shouldn't, it's really risk benefit. Now, if you're on a blood pressure medicine, and they've been studied for decades, many blood pressure medicines, and over millions of people, and most blood pressure medicines have been evaluated for safety, I would say there is a lower likelihood of a problem from being on a chronic blood pressure medicine versus not being on a blood pressure medicine and have uncontrolled high blood pressure. So the short answer is stay on your medicines in order to control your blood pressure. Or the better answer is if you have risk factors that you can mitigate, weight loss, eliminating tobacco, eliminating alcohol, eliminating salt, that would be the foundation before even blood pressure medicines and or in addition to blood pressure medicines.
All right, sounds good. And I think with those elaborations from everyone, that answered several other questions that people in our Q&A have. So if you guys, I'm going to try and address some of the questions in the Q&A. Thank you again. I was so happy to be able to talk to you all and kind of moderate these questions. Great answers. And I'm sure just with the time that you guys contributed today that someone's life has been saved today. So thank you.
Thank you, Shawanda, for that wonderful session. I thank the panelists again. And I'm going to reintroduce our president of the Charlotte chapter of the Links, President Tony Freeman, to close us out.
Well, I feel like I have so much medical knowledge today, I might. Well, no, I don't certainly know enough. But again, Julia, thank you so much for sharing your personal story. We really appreciate it. It just adds so much context to all the good education information that we're receiving. Aaron, as the Executive Director of the American Heart Association, we want to make a special presentation of $1,500 from the members of the Charlotte chapter of the Links. Individual members have contributed. This means so much to us. I want to remind everybody who's out there that you can make a donation as well. There's information on the chat. You can do it directly to the Heart Association, or you can text 4144. Doctors Adele Anthony Williams and Dr. Jerome Williams, thank you so much for the wonderful information you provided. And Shawanda Spencer, Dr. Spencer, thank you for facilitating the discussion for us. I also want to thank Karen Ross Johnson and again, Dr. Shawanda Spencer, who are co-chairs of our committee that put this program on together with other members of our chapter. And then the technical assistance from Kara King and Susan Branch, who are kind of the musicians behind the curtain, who made sure that everything went so smoothly. We also want to remind you that we have a special event. It's called Dance Fitness for Health, Heart Health. It's going to be next Saturday at 9 a.m., Saturday, February 20th. Shirley Zuma Houston Aluko, who's also a member of our chapter, is going to facilitate that, and she does a wonderful job. So it's a great way to get started. You heard about exercise, but we've got an opportunity for you to have fun and exercise next Saturday. Thank you so much for being part of our program, and we hope that you'll support the American Heart Association, but more importantly, support yourself. Be healthy.